think we can go ahead and get started. I anticipate a few more people will join up. Um, but let me just get an introduction rolling here. I'm thrilled this morning to introduce Dr. Wayne Jonas. He is a widely published investigator, a practicing family physician, and professor of medicine at Georgetown University in Washington, D.C., and at Uniformed Services University of Health Sciences in Bethesda, Maryland. Dr. Jonas was director of the Office of Alternative Medicine at the National Institutes of Health from 1995 to 1999 and led the World Health Organization's Collaborative Center for Traditional Medicine. He now advises national and international organizations on ways to implement evidence-based healing practices in their medical systems. He serves as the president of the Healing Works Foundation, a not-for-profit organization dedicated to the integration of healing and curing in routine healthcare delivery. Today, Dr. Jonas will speak on whole person cancer care and integrative oncology. So, Dr. Jonas, we are honored to hear you speak.
Well, thank you very much. I appreciate you having me. Appreciate that introduction. I want to send a shout out also to Audrey Stillerman for organizing this, and to my friend Linnea Larson, who I see has also joined and have a long time relationship. And we served on the White House Commission for Integrative Health many, many years ago. So, and appreciate this opportunity to share some of the insights and thoughts from a lot of the work that we've done across the country with cancer centers around what it means to provide whole person care, which is the topic of this. I'm going to start sharing my slides here, and let's just get this at a full vision. Let me just check with you all, make sure you can see these, that they're, the full screen view, and that you can hear me. Is that okay?
Yes, it looks good.
Okay, great. Let me find this again. Oops, disappeared on my side. Nope, there it is. Okay, great. So whole person cancer care sounds a little daunting when people hear about it. It's like, how do I take care of the whole person? I can barely take care of the cancer. But I hope after this talk and opportunity to have a discussion or answer any questions, you'll find it a lot easier. And I'd like to leave you not only introduce the concept to you, but talk to you about the rationale behind it, why it's important to do, the evidence that's here, examples of how leadership in cancer care is occurring in these areas, and then give you some very practical tools in those areas. Thank you for that introduction. I won't have to go into any of those aspects of my background. I will point out that I've had the great opportunity to work for nonprofits or the government for many, many decades, and have no commercial conflict of interests or other conflict of interest that I know of to advance some of these ideas. What I hope you take away from this talk is number one, understanding what is whole person cancer care. I want to define it for you. It's always a good place to begin. A little bit about its rationale and the science. To summarize how bringing the patient to their uh, own care is a way to optimize both quality and length of life for cancer patients. To review examples of whole person care happening around the country in oncology, and to introduce some very practical and accessible tools, no matter where you are in your system, that you can allow and begin to do on Monday to make whole person care more routine and regular, which I think most people would like. Well, you can't do whole person care if you don't know what the whole person is. So I want to start off with some definitions of really describing what do we mean by a whole person. Now, there are many models that have been used to talk about human flourishing and what it is that humans need in order to thrive and heal. The one that's still the most compelling in my mind is Maslow's hierarchy of needs. Most of you learn this in Psychology 101, or at least have heard about it. And now, 70 years later, it still has a resiliency. He talked about basic needs at the bottom of his hierarchy, safety and psychological needs, then esteem needs and belongingness. And then as you went up the hierarchy, most people thought at the top of his hierarchy was self-actualization, but at the end of his life, he modified that and he said, no, it's not about just self-actualization. There's something beyond that called self-transcendence, the spiritual and service components of life that bring meaning and purpose. And this is the hierarchy that he felt like people got their basic needs first at the bottom, then psychological, and then spiritual components. And while all of these are still fundamental things for human flourishing, we now realize 70 years later that there's a few tweaks and modifications that are needed from current evidence. One is that it's not a hierarchy. It's not something you fill in the bottom and then you go up to the top and eventually, get to self-transcendence. And in fact, there are many groups that do not have many of the basic needs, as many of you know, even at the bottom, and yet they're very full in the spiritual area, the psychosocial area, and this provides them with resilience and it influences their health and well-being. And many of you also know people that have all the basic needs, in fact, many more than that they need at the bottom, and yet their lives are empty because they haven't actually identified what's meaningful and purposeful and engaged in those activities. And so it's not a hierarchy. We also know that all of these things interact with each other. They influence each other. So it's not separate. It's more like what I've drawn in the figure in the center of this slide, which shows an individual as a network of interacting components. And we've simplified the components of it to be more reflective of what it looks like in real life. With the body and the external components on the outside that we see mostly, and they're easier to deal with, and it's what we mostly deal with in medicine, the physical components of it. But underneath that, with a little bit of probing, are key factors of behavior and lifestyle. And under that are the social and emotional components, which are always there. Doesn't mean you have a mental health issue or a social and emotional issue. All have a social and emotional body, which influences what we do and what we don't do. And then finally, at the very center, sometimes at the core of us as human beings, is what I call the spiritual and the mental needs. Why do we get up in the morning? What's important? What gives us meaning and purpose? Why do we even want to have health? And so this framework, this whole definition and description of a whole person is what we use to advance whole person care in those areas. So, in addition to knowing what a whole person is and what they look like, and what's more subtle and invisible compared to what's more visible and easier to deal with, there's another aspect of whole person care that is key, and this is the factors that generate health. The technical term for that is salutogenesis. We all are familiar with the term pathogenesis. We studied out of the textbook in medical school. I studied the textbook of pathology. We look for pathogenesis, we identify it in medicine, and then we try to treat it, usually when it's fairly late in the process. But salutogenesis is the flip side of that. It's constantly going on. It is the genesis, the creation of health, saluto and genesis. And here is where behavioral integrative healthcare integration is essential. We tend to neglect this in healthcare. We treat the disease, but then don't facilitate those components which drive our health in the other direction. And so whole person care requires that we incorporate support services and interventions that facilitate and stimulate this inherent healing process of salutogenesis. Once you know what a person is and the importance of salutogenesis in this, then the approach to whole person care is pretty straightforward. Number one, you have to make sure you know what the person is. What's at the center of what drives them in life. Why do they even want to have health? We call that finding out what matters. And it involves asking them questions like, what supports joy and meaning in your life? A question that doesn't come up too often in the clinical encounter. And we're suggesting it needs to be at the center of the clinical encounter for chronic disease management. Number two, it's holistic, and I've outlined the four dimensions of a human being, which make it holistic in those areas. And the most important thing is that we don't neglect any of these. We don't just deal with the body and then pretend the social and emotional and the spiritual and mental components are not important, or especially in cancer, some of the lifestyle important areas that I'll go into in a minute. And then finally, we have a system and we have an ability to help support the salutogenic components, not just treating the pathogenesis. That means identifying what are the personal determinants of health or drivers of health, and how do we support enhancing and making those happen. Well, what does this look like? Let's get practical here and talk about what it means in cancer. Now, here's a graphic that I like because it sort of depicts an individual as she kind of goes along with her life, and talks about what occupies her attention in life. And you can see on the left part of this timeline, lots of things come up that come and go in her life and that bring her attention. And then she hears the word cancer. And the doctor says, "Oh, you have cancer." And suddenly that crowds out everything else. It is, as we said in the military, it's like pre-boom and post-boom after the bomb. And suddenly this subsumes her entire life. She then ends up engaging with medicine, with the oncology team. And suddenly her life is filled with things that are important to them, for treating the cancer, the labs, the scans, the surgery, the chemo, and markers that are documented in her chart through something called the SOAP note you're all familiar with. And this is the tumor response, the treatment plan, the treatment toxicities, etc. And all those things that were on her, in her attention over on the left-hand side that made up her person, her family, her friends, her work, childcare, body image, etc., tend to be neglected. Occasionally they're asked, but at least immediately, they're not the focus of the oncology team, and they're also not captured in the SOAP note. And we've come up with some other tools to help discuss what goes on in the person when these two worlds collide. Now, let me show you an actual example. This is not her actual name, but this is a real patient, and it is a very common type of patient, increasingly as people are surviving longer and longer with cancer and after cancer. She was diagnosed initially with breast cancer at 34 years old. Unfortunately, something that's becoming more common. She was a mother of young children, had a busy career at that time, diagnosed with breast cancer. And over 30 years that she dealt with that and others, she faced seven more cancers, three of them life-threatening in those areas. And again, we see this happening more and more in these areas. Now, if you went to the medical record and you looked at what the oncology team had documented, here's what you would see. You would see the diagnoses and the stage and the treatments. You would see other cancers that came up over a period of years, including a second breast cancer, ovarian cancer, and then the treatments for that in those areas. And this is what you'd get if you could get a comprehensive view of her medical record, which you could not get because she had this done at multiple places that don't integrate. So that was one of the ongoing problems, is even knowing this particular history. Um, Eventually she entered some clinical trials in those areas, and those were even more opaque in terms of figuring out what happened to her during that. But if you asked Jan what impacts her life, what was important to her during this journey, you could not find many of these in the medical record. They're just not documented. And here's the kinds of things over those 30 years and through multiple cancers and its treatment you would see. I've highlighted a few. Fear, no time. She ended up quitting her job, which is important to her. She gained weight after the initial breast cancer, and no one began to talk to her about the importance of that for long-term health. Not one discussion during that time. Insomnia, loss of libido, lots of regrets, distress, and worries. And then, as these other cancers popped up, questions about the proper management of them and confusion over there, those areas. And yet, these are things that were important to her, but very few of them were actually addressed. Now, fortunately and unfortunately, this is becoming much more common, and it is a core part of what you all see in cancer survivorship. Overall cancer mortality since the time that Jan was initially diagnosed has dropped by 33%. That's very good news. It's averted over 4 million cancer deaths during that time, we estimate. At the same time, that has resulted in a growing number of cancer survivors. 7.9 million at this point, and it's estimated by 2040 there'll be 26 million cancer survivors, people living with cancer and or with cancer treatment consequences during this time. And so the importance of addressing the person as a person and their own life and not just the cancer is becoming paramount. Now, the reasons for this drop in mortality has not largely occurred because of new drugs. Now, you hear about breakthroughs, and occasionally there are breakthroughs for small groups of patients to advance survival. But if you look over the last close to the last 20 years of FDA approved drugs for cancer treatment, the overall survival gain from those is only about 2.8 months. So this is not the reason for the rise in cancer survivorship in those areas. In fact, we now know that there are multiple other factors that have not to do with treatment so much, but have to do with behavior, they have to do with lifestyle. That is part of the reason that we're seeing survival. Many of them are things like smoking, obesity, alcohol use, poor diet, and inactivity. If you remove smoking, which everybody knows and is probably the number one major cause and has been declining, there at least 18% of all cancers diagnosed are related to things like excess body weight, physical inactivity, alcohol consumption, poor nutrition. If you add to that the improvements in cancer screening and early detection, we have the reasons why we now have higher cancer survivorship and a lower mortality rate in those areas. And so addressing behavior is key to these areas, and doing it without blame is also key. Jan did everything. She ate organic, she did yoga, she exercised, she had a good family life, etc. And yet she still got cancer in those areas. And she would often come, and many of you, I'm sure, have patients that come in and say, I do everything right. Why did I get cancer? And they're struggling. And if that isn't delicately approached, sometimes they feel like, they are to blame for producing their own cancer, which is the last thing you want to see happen to them. Before I talk a little bit about how to properly bring in these kinds of behavioral changes, let me just point out that the cancer biology also calls for whole person care. It's astounding to me that we have so much knowledge now in the process of cancer development and its regression that we do not take advantage of in these areas. We used to think it was just the tumor, it's this rogue growth, and that we just need to kill it. And unfortunately, the approach that we take to that still has that framework and that paradigm. But we now know that the biology says that this does not happen in isolation, that there is a tumor environment in which this occurs, and that's just as important as the tumor itself in whether the cancer progresses or regresses. These are called the hallmarks of cancer. They've been well documented and described in the scientific literature behind them. I've listed the main ones here, the 10 hallmarks of cancer, most recently summarized, and they fall into categories like metabolism, immunity, inflammation, and increasingly the microbiome. Which influences all of the others. So the biology of cancer says we need to pay attention to these factors and the environment that it exists within. Let's just pick one of those in the tumor environment, and that's the inflammatory aspect of it. We know that the inflammatory microenvironment around the tumor has a big influence on tumor development, and that the macroenvironment, what the person does in their life, also has an influence on the microenvironment. So this means that here's an example from published in Nature Medicine several years ago that I think nicely summarized a massive amount of scientific literature illustrating how chronic systemic inflammation leads to multiple conditions, including cancer that I've highlighted on the right-hand side, but many of these other conditions that are part of survivors' life or can be part of survivors' life in health and disease in general. And if you look at the left-hand side, we see some of the major factors that contribute to systemic chronic inflammation. And again, they are behavioral and lifestyle connected: dysbiosis, diet, physical inactivity, stress, disturbed sleep, obesity, etc. And so the biology really calls on us to pay attention to these things if we are really wanting to optimize the management of cancer and its survivorship. This means we have to pay attention to the components of wellness and well-being, such as activity, diet, sleep, love, and the social environment, if we're going to influence these hallmarks in those areas and paying attention to these. But Jan, unfortunately, never had those discussed with her through most of the time that she was there. I don't have time to go into the extensive data that has arisen over the last few decades on many of these factors, but let me illustrate just a few of them, how wellness behaviors influence cancer. And this occurs both leading up to the diagnosis and after the diagnosis. 10% increase in the amount of ultra-processed food, for example, in the diet causes significant, more than a 10% increase in cancer risk. Social support is something that we see, but rarely have an organized way to address. And yet, the data shows that that high levels of social support reduce the relative risk of dying if you have cancer by 25% compared to low levels of social support. That's better than almost any drug that you could get in these areas, and yet we rarely address it. Physical exercise has emerged as one of the areas with a major influence over cancer and its progression. It's been shown that walking for as little as 30 minutes a day lowers the risk of 7 different types of cancers. And a recent large randomized controlled trial of post-diagnosis colon cancer showed it reduced mortality by a similar kind of percent with supportive exercise. Sleep is something that influences all of our health components, from the immune system to our psychological and stress management, and yet close to 60% of cancer patients experience disordered sleep and disruption in those areas. And so attending to these areas should be part of standard cancer care wherever we go. Now, how do we do this in a way that, doesn't blame the individual or the person doesn't feel guilty about? Well, we have to do it by having systems that engage them, that realize that we are partners with them, and that their engagement in these things can have real impact on their survivorship and their quality of life, and bring them hope in doing that, and then have a system that supports those salutogenic factors that they can effectively engage in. And this involves behavioral care in those areas. Often I hear oncologists or oncology teams will say patients aren't interested in that. They only want to have their cancer treated. And this is not true. Here's the results of 2 surveys that we commissioned over several years looking at interest in a variety of integrative and whole person cancer components. And it's very high for the patients, which is shown on the left-hand side of this graph. Excuse me. And in most cancer centers, especially some of the larger ones, such as those at UIC and others, these services are available to help in these areas, and they're increasing in those areas. What often happens is that you don't even know you have them. For example, there was a great supportive area and integrative services available where Jan was, and yet her oncologists, not a single one mentioned it. They either weren't aware with it or they didn't know how to incorporate it into the healthcare plan, and yet it was available. She had to find out and access it on her own, and nobody actually brought it into her healthcare plan. Had that happened over the 30 years of Jan's treatment, there are many things that could have improved both her quality and her length of life in those areas. Just take one of those. While she was on an AI inhibitor, for joint pain, we now know that acupuncture and hypnosis can significantly help with that. So fatigue and insomnia have many approaches, exercise, yoga, cognitive behavioral, sleep therapy, etc. There are many drug and non-drug approaches to the management of depression, and weight gain now should be a standard part of what's addressed because we know it is such an important risk factor for subsequent cancers, such as what she got. But no one actually referred her to a nutritionist or discussed her weight with her in those areas, as well as other things that are recommended with early palliative care, but she did not get until late, as is the case with most people, to help deal with her fear, her hope, her aspirations in life. Um, Now, this doesn't mean we have to have all of those things that I just listed for Jan's care at the same time and available. As my co-author and colleague Alyssa McManaman, a VA oncologist, has said, any clinician can deliver whole person cancer care. At its core, whole person cancer care is about seeing an individual beyond the disease or illness, and it's learning about and partnering with them on what matters now. And I'll emphasize the now here, because if you ask what matters now during each phase and stage of cancer, this allows you to really do person-centered whole person care. Towards the latter part of Jan's cancer journey, or when she was undergoing intensive treatment in those areas, if you asked her what was important for her right now in the management, she would say, I want to spend time with my grandson." She had a new grandson at the time, and Fridays is our sacred time. We want to, Friday morning is the time I pick him, or early afternoon, I pick him up from school. We spend time together, and then he stays over, etc. And it's some of the best time in my life in those areas. And so that was what mattered at that particular time with for matters. So that should have been brought into the treatment plan and communicated to the team, but of course was not. And so that was the sacred time that the team, the cancer team that you see here, if that had been built in to her treatment plan, people would have known not to schedule visits during that time, and to make sure to pay attention to the management of her complex situation. Navigators can help significantly with this as long as they're not navigators whose sole purpose is to serve the institution, but if they're more advocates and to serve the patient and adapt to the patient in those areas. And many navigators do this. These kinds of discussions can be brought and have been brought and are brought into case conferences so that a personal health plan, not just a tumor treatment plan at the tumor board, is brought into that. And again, in survivorship, this is especially important. It's not like cancer leadership. This has gone beyond them. In fact, at most ASCO meetings, usually the president of ASCO will emphasize the importance of whole person care. Here's two of the most recent ASCO presidents' keynote talks at ASCO. And as you can see, they both talked about the importance of partnerships, of relationships, of getting to know the patient as a person, bringing in the art of care and the human side of cancer medicine early on and continuously in the care, supporting it through their care in those areas. And despite these calls for this, it happens very rarely for a variety of reasons that we can talk about in a bit. Now, in palliative care and supportive care, this has been the mantra for many, many years. Here, some update on guidelines on palliative care. And when they talk about the essential components of care, which they recommend occurs with every person with advanced cancer within 8 weeks of their diagnosis. And if you look at this list of things that should be included in that, they are very holistic in those areas, including addressing sleep, mood, nausea, constipation, and other symptoms, but even broader areas in those areas. And yet, as most people know, palliative care does not occur for most people until pretty close to the end of life, and there is a shortage of palliative care components. There are also missing elements from these recommendations especially for survivors in those areas and earlier on in the cancer care component. And this is the reason that the whole field of integrative oncology has arisen in those areas. And so some more recent guidelines that have come out from ASCO and from the Society of Integrative Oncology, excuse me, focused on pain and pain management, anxiety and depression and fatigue, have looked at the science and made recommendations in those areas. There's two more guidelines that are about to come out in these areas, one this year and one next year, or next in the next 2 years that will do this. And if you just look at some of these guidelines, there is good evidence for certain things that have started to emerge. For example, in the pain area, a treatment is now recommended for AI-related joint pain. One of the symptoms that Jan had is acupuncture. She fortunately got acupuncture and prevented progression of peripheral neuropathy that occurred in those areas. But there's other areas with less evidence and yet are safe and often can be made available and can help with individuals such as massage and acupressure, etc. In the anxiety and depression guideline, there's strong evidence that mind-body interventions, mindfulness-based interventions should be offered to people both during active treatment and post-treatment for the management and very successfully of anxiety and depression. There are varieties of ways of delivering that, including some of the ones listed underneath here, such as yoga, which many people find very helpful. In the area of fatigue, there's a whole list of potential issues that have come out in those guidelines, exercise being the number one supportive care that can mitigate and reduce fatigue even during treatment, cognitive behavioral therapy, mindfulness, and perhaps a few other supplements. After treatment, yoga, acupuncture, and others can have some benefit, and at the end of life, some medications and cognitive behavioral therapy seem to be the most useful in those areas. Cost matters, and so without addressing the financial toxicity of many of these treatments, people, often cannot access or feel empowered in taking care of themselves. It's been shown that 4 out of 10 people said out-of-pocket costs were higher than expected, and bankruptcy is often caused by medical costs that were unanticipated in those areas. Health disparities is a huge area, especially trying to get whole person care. Cost is one of the major reasons for that and a deterrent in minority and underserved populations with cancer. Yet psychological counseling and integrative services are used significantly less. There are cultural and religious biases that can also interfere with that, people that are not trained in culturally appropriate care, and it's less available out in community-based settings than in academic or center settings, and therefore gets less access in those areas. The AMA and others have said that trust is at the center of engagement and equity. Cultural competency is the process for addressing that, including linguistic issues, cultural humility, appreciating the patient's experience, again, asking them and listening to what matters to them at each of the visits, and then having care reflect the patient population so that they can trust the care adequately. Now, we took a number of the tools to try to facilitate whole person care in primary care that we had been developing for years. I'm a primary care physician, a family physician, and I had tested those tools out in a network around the country and published that in multiple publications showing how they're used and how they were taken up in those areas. We then decided because the gaps in cancer care and survivorship were also so great, there needed to be an initiative in those areas. And so we pulled together something called the Integrative Oncology Leadership Consortium or Collective. Here's a list of a few of the people through the groups that were involved in that. And we translated those tools for whole person care into cancer care. And those are now available, and I'll show you some of those areas. This group then looked at, tested out, and evaluated those areas. There's been three now ASCO publications and abstracts presented. I just show you two here that talk about the minimal required elements for whole person care. I've listed some of those there. Making sure what matters is a question that the patients and caregivers' voice are included in the discussion right up front, and then providing salutogenic and safe choices in complementary, integrative, and palliative care and supportive care services. There were many common challenges found across these organizations. I've listed a few there. Those implementation challenges were addressed in many centers and could be addressed in many centers, often customized to their particular environment and their particular needs. And there are a number of case examples published on our website from several of these centers about how they implemented then aspects of whole person care in their centers. Just illustrate a couple of those that might be of interest to you. At the Marshiner Cancer Institute, part of Penn Med in Allegheny Cancer, they altered their survivorship program, which was largely a screening program for future cancers, and turned it into a survivorship and wellness program. They hired a primary care physician trained in integrative care to actually help run that and address the wellness components that I just talked to you about more effectively. Another case study is that of the Inova Shar Cancer Institute in Northern Virginia. They have a robust Life with Cancer program that was started 25 years ago with individual donation. And over that period of time, it has been embedded into the culture of care. So now it's at the center of the Shar Cancer Institute and is covered by institutional costs, not just by philanthropy in those areas. It's open to all adults, survivors, and caregivers that work with that live in this particular area. They don't have to just get their care at Inova. The Sidney Kimmel Cancer Center, Jefferson University then created a cancer support and wellness program to translate and use the personal health inventory into Spanish for those populations. They then emphasized and developed more thoroughly a cannabis medicine certificate program and brought an oncologist into their integrative health department that they have there to provide that type of care more effectively. So, what does all this mean for you all where you're at? What can you do on Monday to begin to do more whole person care? I think there are a number of things, and it depends a bit on where you sit. And I'll challenge those who are system leaders, which are key to this, that they make whole person care a key part of their practice or quality improvement. The changes and the improvements that you're constantly going through in your system design, and the enhancement of salutogenic or healing services in those areas. And I'll show you in some of the examples that I gave you, they did just that. If you're a clinician or a clinical team member, I'd suggest one thing, and that is pick up the personal health inventory. I'll show you how and where to get it in a minute, and then begin to bring it in and try it out in practice. To with your patients. You'd be amazed at how this streamlines the discussion about what matters to patients in a non-threatening way and helps to educate patients about their involvement and what they can do proactively in those areas. Of course, if you're a patient, tell your care team what you need. Answer the question whether they ask or not about what matters to you, and bring an advocate along with you. Someone who is your navigator, not just the system navigator. And if you're a caregiver, of course, be that advocate and come prepared to help do that. So what does this maybe look like? Again, if you're a system leader, here's what large systems have done. This is a model that was recommended to and has largely been adopted at different places within the Veterans Administration. It is this was published in a JAMA Health Forum a few years ago, called the two-circle model of whole person care. And what it does is it integrates the pathogenic treatment that everybody has or should have in those areas and integrates the salutogenic components that we've just talked about and the wellness components into the personal health plan in those areas. Uh, and this has been done outside the VA at a number of different centers too, and some of the case examples I've shown you have shown that. You have to make this one of your innovations, if you will, in your practice and your quality improvement program to get good outcomes. If you're a care team or in charge of a care team, create a pathway for a whole person care visit. This again is described on our website, but it's fairly easy to design. It's just like any other care visit. It usually starts after the treatment visits have occurred. Make a special appointment for for person-centered or whole person care visit. You can use pocket guides. I'll show you where to get those in a minute to explain what that is to patients. Do a person care visit based on the personal health inventory that gets incorporated into the personal health plan, addresses what the needs of the patients are, as I've illustrated you, and then help the team in case conferences and through case coordination, navigation, and advocate to support those needs on a regular and routine basis, just like you would the tumor treatment plan in those areas. Here's the tool I mentioned to you. It's called the Personal Health Inventory. It is a simple two-page questionnaire that you can either you can either send out electronically before the visit or even just print out and give to your patients in the waiting room. It takes maybe 5 to 10 minutes for them to fill out. The key unique feature of this is it asks the patient what matters to them. It asks them to describe what it is that they love about their own life and why they're looking for improvements in health. And then it has them rate the key factors that they can engage in to improve their own health and what their priorities are in those areas. And so that can serve as the basic conversation that then gets documented in what we call a healing-oriented practices environments note or a hope note. It complements the SOAP note into the electronic medical record so the team can track and follow what matters to the patients on a routine and regular basis. So try it out. It's easy. It's free. You can get it from our website. It was originally developed, or a version of it was developed within the VA for their whole health program, but we've adapted it so that it has first, there is a primary care version and then a specific oncology version that the Oncology Leadership Group that helps to develop. There is an electronic form of this that you can send out. An individual can fill it out, and then you can even put your Hope Note directly into it and integrate it to the electronic health record more easily through a group called the Smart Measures in those areas. Now, many of these and many other resources are available on our website at healingworksfoundation.org. These are all free and available to take, bring into your system, rebrand into your system, and use as you wish in those areas. These often come in the form of what we call pocket guides for whole person care, which summarizes the science, the issues, the financial components for multiple here. Here's three of them that are available in those areas. We've taken these over to the American Cancer Society, and they have looked at them and said, we need more of this. And so they've began to incorporate many of those guides into their call centers and are now into their navigator training and eventually into their clinical training programs. And so you'll see them more widely and readily available through standard sources like the American Cancer Society. And here's a list of ones they've already adopted and brought into their system in those areas. If you go to the website, you'll see several buttons. One, we have resource tools for primary care, for general medicine. There's a special one for cancer care. Notice the ones for CME courses. These are free CME courses on how to do this if your team or clinicians are interested. And then if your patients want to know about it, there's a button that will take them to a patient landing page called How We Heal that's specifically oriented for cancer that can, in patient and lay language, describe what whole person cancer care is and what we know about those and how they can access them more quickly. I mentioned the CME course. There is a 5-hour free CME course in whole person cancer care developed by the Tufts University Center for Information and Education. And you can go there and take that, and that has been very popular also. Dr. Alyssa McManaman, an oncologist at the VA in Dayton, Ohio, and myself wrote a book on this. It's called Healing in Cancer, available pretty much anywhere. There is a guide for studying it if your team's interested in using it as part of your practice improvement component in those areas. And then I've previously written a book on this in general medicine called How Healing Works. So again, I hope this was helpful for you and provides you some both rationale and practical resources for doing this next Monday when you start, wherever you sit in your particular system. And I look forward to having a dialogue and hearing any questions people might have.
Thank you, Dr. Jonas, so much for that talk. That was just amazing. We needed to hear that. Everyone needs to hear this, right? Um, Thank you for all the work that you've done in this area to advance whole person cancer care and integrative oncology. It's inspiring and is something we've been working on incorporating at UIC, and we'll definitely be using those resources at the Healing Works Foundation. And yes, that Tufts Whole Person Cancer Care course also available through the Cancer Survivorship Provider Network. I will include that link in the email in the follow-up with a link for a recording of this talk, so everyone can benefit from it. I love your hope note, and just identifying what's important to patients because it's not always necessarily a symptom that they're feeling, right? And that's what we too often boil it down to. And it's thinking more about exactly the whole person. So I appreciate this talk very much. Does anyone have any questions and want to jump in? Uh, Feel free to unmute. I have a feeling our director of prevention and survivorship, if she's here, will want to chime in.
So Deb, I can
And
start. Wayne, thank you so much. This was great. Your slides were tremendous.
Mhm.
And I really appreciated on your focus on cultivating health in addition to our usual focus. I actually want to ask you to talk a little bit more specifically about how some of the centers that are doing this addressed the kind of perennial problem, excuse me, of finding time. What are kind of some ways to just, open the door um, and make this a reality a little bit at a time? Because I think that, as you know from your own practice, there's that pressure, and trying to figure out how to do something new can be very challenging.
Yes, no, I think time and resources are the major things people feel like and are a challenge in these areas, especially because cancer care is so complex and it gets more complex and more challenging to deal with things as as knowledge improves and things get more complex and more difficult to integrate. Excuse me. What these centers have found is that you can't just talk about time. We spend a lot of time actually taking care of patients, and it's a matter of who's using the time for what, for their particular role. So you have to talk about the time and the team. Okay. Most of these kinds of support services that I've showed you come in under the two circle model are not delivered by the oncologists. And as I showed you in the surveys we did, most of them are actually available, especially at the larger centers. They're actually around. And the problem is not so much time as lack of organization so they can be efficiently integrated into the actual delivery of the care plan. Somebody hasn't just sat down with a whiteboard and said, hey, here's how we're going to do this each time through the care path that we've talked about. And here's the responsibilities and the roles that different team members have for doing that in those areas. And so very often it's this integration factor that becomes the most important. Um, One of the most time challenged groups that we have worked with is a safety net hospital up in Queens, New York, that has huge challenges, has no insurance, and yet has now trained and created the navigators that they had that were primarily community and healthcare navigators and trained them in health coaching and becoming patient navigators and empowered them to come into the case conferences and say, this person says, I need this, and we need to make sure this gets incorporated into their healthcare plan. And that can sometimes preempt what the oncologist says in terms of the delivery of the care. And then you go over to another place and the navigator is simply making appointments and helping the thing out. So it's really about organization in those areas, and it's the team that does this. The oncologist is key, and we've done surveys on this also. Patients want the blessing of their oncologist, and they want to hear from their oncologist that this is important. They want to hear that the oncologist says, this is worth your time because it's worth my time to point it out to you and to make sure that the care that you're going to get is incorporated that. But it doesn't mean the oncologist provides all of that care. They just have to make sure that their team is actually integrated and organized in those areas. And that often relieves them of the time in those areas in those areas. And it also a number of these surveys have shown this improves the satisfaction that people have because they get to know the patients better in ways they didn't have, and they almost always look back and say it wasn't the number of Whipple procedures I did, but it was I remember this what this did to this person's life, and I wouldn't have known that unless I'd asked about their life or somebody had asked about their life, and I understood that as I was tracking their care.
Hi, my name is Linda. Can you hear me?
Yes.
Hi, great. I'm a breast cancer survivor and former practice manager for a breast clinic. I happened to have had breast cancer when I was working for a physiatrist, though, who is a functional medicine practitioner. So I put in practice a lot of these things 15 years ago to myself, and I love seeing it all in one place. Thank you so much for your information and for the work that you do. My question is there anyone who's modeling after cardiac rehab to have 6 or 8 week program for cancer survivors that's standardized, just like we have cardiac rehab many years ago?
Yeah, you bet. That's a great question, and the answer is yes. There is an entire organization that focuses on that. It's called the International Cardio-Oncology Society. Okay. And they are extremely holistic in what they do. These are mostly cardiologists. They're trying to get the oncologists to get more engaged in it. They have an annual meeting every year. They have developed a comprehensive evidence-based plan for managing an individual's cardiac health that has cancer and has either undergone or will undergo or has finished cancer therapy. And that group is a model of how to do this. Okay. And they have guidelines, they have training programs, and they're not just about the heart, as you can imagine, because cardiologists are really about behavior and lifestyle and prevention for many years. But they've now integrated this with cancer and cancer care. So I would look them up, and maybe you can get their president to be the next speaker at your or one of your speakers at your conference here. They're a great society.
That'd be great. Thank you so much.
Mhm.
Thank you all so much. And thank you, Dr. Stillerman, for that great question. And Dr. Jonas and Debbie, I'm so grateful for this. I'm in a collaborative care model as a psychiatric nurse practitioner, and I'm also a survivor, and was lucky enough to have it's called True North Treks. They do outdoor and mindfulness-based interventions for young adult cancer survivors. And it made such a huge difference in my life because have always been outdoorsy, but this was like taking it to a next level with health and wellness and mindfulness, and really made the difference for me. But I also have a question about this protecting providers from burnout, because I think, as you say, there's that patient satisfaction of really getting to know people, of knowing more about them than just the soap. And I wonder if there's work, because this is something I'm doing in my life course disability clinic, to look at burnout from a provider standpoint and how this can protect us in that way too.
Yeah. Well, there was a lot of burnout in the military during the last two Gulf Wars, and I took care of a lot of those patients. And uh, uh, we had something called No More Yoga, because they would put in lots of these supportive care components to try to mitigate, people's burnout by providing yoga and self-care and all that kind of stuff, when the system itself was burning them out, and they needed to reorganize that. So this is not a magic bullet. Behind a system that is economically driven and therefore, is looking for you to do more and more. And I'll give you an example of that, very salient, I'm sure, to most people, and that is AI. Okay, AI is seen as sort of the savior of burnout, right? Because it's going to give you more time, and yet we see systems using AI to replace clinicians or add additional visits, because now you've saved half the time, right? On the medical record, which is one of the biggest problems in burnout, is trying to document all this kind of stuff in those areas. And it's documenting stuff that is menial in the sense of the person. Uh, and so interferes with the ability to make this personal connection and relationship. And again, most clinicians will say, what I get most satisfaction out is not working. What causes a burnout is not working too much. It's the fact that I can't address the key issues that are important to my patient, and I can't connect to them. And this allows them to do that. And we found in those that were beginning to implement these whole person care visits that they actually had a reduction in burnout and an increase in satisfaction. They really wanted to do it. Many clinicians had tried at first to delegate this to the team, which it should be, the support process and the management aspect, but they wanted to have that initial visit. They wanted to sit down and talk about the PHI and put the first hope note together because they liked it. They really enjoyed it, and they got to know the patient in many ways in those areas. So I think this could be a tool for burnout, like any tool. It could be used right or wrongly in those areas, and can become a checklist that becomes a burden in those areas, or it can become something that can kind of relieve you from a burden that is otherwise causing moral injury or other kinds of injury in those areas. Uh, so group visits are a great example of how to relieve some of this kind of area because many lifestyle behavioral components, and you mentioned the outdoors and the engagement in activities and things like that. I showed you a little bit of the evidence showing that exercise is important for quality and length of life in cancer patients. And yet people very often don't want to just go to the gym. And that's what we think about, right? Send them to the gym and do that. And that's very boring and that kind of thing. But if they get engaged in a group that's doing it, then they'll get it done and they'll actually feel better. The randomized control trial in colon cancer I just mentioned to you, that was the key thing that they did. They brought people together in groups and they had incremental, very small amounts of increase in actual cardiovascular fitness, but it had significant impacts on their recurrence rate in those areas. So very simple approaches sometimes can be addressed that can alleviate burnout and really be very satisfying in terms of both the patient and the clinician.
I realize it is after 10 o'clock, and some folks may need to go. And but yes, thank you so much for this talk. If you are available to stay, I'm sure people still have questions, but everyone who has to leave, I will be sending out a review recording link once available. I work with our marketing department to get this on YouTube. And also the link to the CSPN course on the whole person cancer care. But yes, and I just wanted to say, yeah, Dr. Ganshow had to hop off, but she is our Director of Prevention and Survivorship at the Cancer Center at University of Illinois. And she said, Monday, we're going to make some changes to incorporate much of this into our survivorship program. This is
Glad
a
to hear it.
lot of the core things we do. We talk to everyone about lifestyle, about inflammation, about, what matters to them and their social supports. That is what we do naturally as a team.
Yeah,
But how
and
can
that's
we
great.
bring this out to more providers? How can we spread this out and integrating those different, not alternative, but complementary, you know, really life-giving therapies that patients benefit from so much, like acupuncture, which I know Audrey is working on with the clinic to start to introduce that, how we can grow that clinic to include mind-body stress reduction activities or, you know, an herbal type of clinic or, what have you. This is something that patients are craving and would love to be able to have. So, so thank you
Great.
very much.
Well,
Is
thank
that-
you for having me, and this is great. I hope this helps you do more and better what you already are doing.
Yes, I believe it will. And everyone go pick up Dr. Jonas's books. Learn how to do this. There was also a great talk, I guess, on CSPN. The recording's going to be available about implementing this in a cancer center in setting as well. So, do you have time? Does anyone else have any other questions? I'm gonna guess no. So, we will sign off. Thank you again for this amazing talk.
Hey, thank you.
All
Bye-bye.
right. Bye, everyone.